In my session, I took a little bit of a historical approach, and so maybe I can also do the same. Is that that's really the name of the game for all of medicine, particularly as we are fully now immersed into precision medicine. It's just a more specific attempt to do what we've always been doing, which is individualized treatment based on underlying disease biology. And cancer and oncology has really been leading the way in precision medicine. So again, trying to understand the patient's biology of their disease and then pairing treatments to that underlying biology. And precision medicine takes that to really its molecular, uh, you know, um, most specific molecular interpretation. And for some cancers, we have that, so not in prostate, but, EGFR mutant lung cancer, we know we can treat those patients very effectively and they respond very effectively to tyrosine kinase inhibitors. Other examples, probably the canonical is CML and, Gleevec. But in prostate cancer, we've been doing that primarily with clinical factors and pathologic factors. So what we see and feel on examination, the pathological findings at the time of biopsy or surgery. We have a great biomarker PSA that helps us. And so, again, I took a historical perspective, crediting Dr. Anthony D'Amico, who's been at Dana-Farber his whole career, really. And he came up with a system using those factors to really risk stratify localized prostate cancer. And my talk was a play off of that, at least at NRG, so I'm the NRG Translational Science Chair. We've been trying to increase precision medicine and concepts in the G radiation oncology space. And although the tools that we have now are more molecular and more sophisticated, so gene expression, digital pathology, and artificial intelligence, it's still playing off of that same concept that Dr. Yamiko really showed us was advantageous to the betterment of treating our patients, way back in 1996. We currently use clinical pathologic factors. Dr. D'Amico came up with his D'Amico classification system back in 96, and there's been modifications to that, the NCCN 3-tier, now 6-tier, CAPRA, STAR CAP, but these are just incremental modifications to D'Amico's system. And so, that I would say that is kind of the past. The present is what we have been doing in the NRG GU Oncology group, is trying to use gene expression, so multi-parametric platforms such as microarray or next-gen sequencing, to again understand that underlying biology and parse out the different risk groups of the patient. So one example that I used in my talk was that we have been very successful with is the Decipher genomic classifier. And there are other classifiers, but our group has partnered with Veracyte, the company behind Decipher, to show amongst many things that this particular 22 gene classifier is very prognostic and has been shown to be independently prognostic for distant metastasis and prostate cancer specific mortality and localized prostate cancer. It's covered by CMS, and again, multiple validation studies. So much so that now we've incorporated this into our next iteration of trials at NRG. So we have 2 trials, which are really the first in the space to utilize genomic integral biomarker design clinical trials. So the biomarker, in this case, the Decipher genomic classifier, is going to be used to risk stratify patients in these phase 3 trials. We have NRG GU009, which is predict RT, and then NRG GU010, which is guidance. And GU009 is led by Paul Lin and Oliver Sartor, and GU10 is led by Ollie Berlin and Neil Desai. And there plays off of this same precision medicine concept of understanding the patient's underlying disease biology, in this case by using this genomic classifier, to then risk stratify patients appropriately into de-intensification and intensification cohorts. One of the features, and I remarked upon this in the talk, is that yes, we're looking at a number of different technologies, next-gen sequencing, a liquid biopsy, but one of the technologies that has really caught our eye is digital pathology paired with artificial intelligence. So we've been working with this company, Artera, and what we've done at NRG is digitize thousands and thousands of H&E slides. So this is a material that you would get in any diagnosis of prostate cancer. It's really standard of care. And so we've digitized thousands of those slides comprising thousands of patients that have been enrolled on our practice-changing randomized clinical trials in the past, where we have very deep clinical data on these subjects, as well as 10 plus years of follow-up. And so we worked with Artera to feed all of this very rich information, H&E, so digital pathology, as well as clinical information, into self-supervised learning artificial intelligence algorithms that are just very, very good at pulling out the most prognostic, the strongest features that correlate with clinical outcomes. And they have come up with a biomarker test that, again, we're validating this now, but it seems to be, again, independently prognostic compared to some of our best clinical tools. This was oral abstracts presented at last GU ASCO, but also at this GU ASCO, demonstrating that this Artera artificial intelligence biomarker seems to be very prognostic. And very excitingly, we also seem to have the first predictive biomarker of its type. So being able to tell us which patients should or should not receive, in this case, short-term androgen deprivation in the intermediate risk localized prostate cancer space. And that was presented last year at GU ASCO. And we more recently validated that finding in a trial, a pivotal trial, NRG RTG 9408, which is one of the trials that informs us and gives us the data to add short course hormones to localized prostate cancer patients. So it's very exciting. So something that I tried to stress during my talk, and and this is very specific for localized prostate cancer, and it doesn't pertain as much to, well, other stages of prostate cancer, or even other cancers, is that in prostate cancer, and just to, during my talk, just to be controversial, to hammer home the point of the importance of risk stratification and precision risk stratification, is that for localized prostate cancer, amongst the options that we have, which are surgery and radiation therapy and some slight modifications of that, we do actually a very good job in curing most of our localized prostate cancer patients. And so precision medicine, as I said before, it dictates you understand the underlying biology and you pair that to a specific treatment. A lot, and this is obviously makes a lot of sense, a lot of the excitement is in new treatments and better treatments. But for localized prostate cancer, we actually have, in the form of surgery and variations of radiation, we probably have most of what we need to cure many of the patients that we see with localized prostate cancer. And so really trying to risk stratify better is going to be, I think, more impactful, because the majority of patients we do a good job on, it's just we tend to overtreat a large number of patients and probably undertreat a minority. So getting back to what you asked, I would say, so NRG GU009 and 10. So 09 is in the high risk localized space. GU10 is in the intermediate space. And they really are the underlying concept is to better risk stratify those patients so that we're not overtreating a majority of patients. And then the minority that we're undertreating, we're giving them the more intense treatment. So in GU 10, which is the intermediate risk trial guidance, the de-intensification cohort as well, maybe we can get away with just radiation alone, in a large majority of these patients. And then the ones that are higher risk, that have underlying biology that's more aggressive, we are in the intensification arm randomizing to standard of care plus darolutamide, which is a stronger androgen type of androgen deprivation or intensified androgen deprivation. GU009 or PREDICT-RT, which is in the high-risk localized space, similar. We have a de-intensification arm because there's probably a fair number of patients that we're over-treating. And then for the ones that we are under-treating, they'll be randomized to standard of care, plus, again, more intensified hormone therapy, in this case, in the form of apalutamide. So I think both trials, those are ongoing prospective trials, and will likely inform us. I think, they're going to inform us tremendously, whether if, quote unquote, positive or negative, but certainly if they're positive, they will change standard of care and definitely improve precision medicine guided treatment in the localized space, which we, like I said, in a very rudimentary way, we've been doing it for decades, but now we'll actually be able to really risk stratify, precision risk stratify, and improve upon that. The other trial that I mentioned is artificial intelligence digital path AI biomarker, was validated in a trial that had already been completed. And so not testing that prospectively yet, but I think what you're going to find is that, obviously that trial will also be, or that biomarker, excuse me, will also be involved in some type of integral biomarker trial design.